Thyroid Emergencies Jim Holloman, MD, FACEP. Professor of Military and Emergency Medicine. Uniformed Services University of the Health Sciences. Clinical Professor of Emergency Medicine. George Washington University. Bethesda, Maryland, USA. Thyroid Emergencies Lecture Goals. Review pathophysiology of thyroid-related illnesses. Present information on recognition and management of medical emergencies related to thyroid diseases. The thyroid emergencies. Previously undiagnosed hyperthyroidism. Apathetic thyrotoxicosis. Thyroid storm. Myxedema coma. Airway compression or superior vena cava syndrome from goiter or tumor. Ancient Greek and Roman coins showing goiters. Maria de' Medici, wife of King Henry IV of France in 1625, with a goiter. Thyroid physiology. Thyroid gland secretes two hormones. Thyroxine, tetraiodothyronine or T4. Triiodothyronine, T3. Secretion ratio T4 to T3 is 15:1. Iodine is attached to tyrosine amino acid residues of thyroglobulin in the gland. Organification. Coupling of these residues then produces T4 and T3. Thyroid physiology, cont. T4 and T3 released by the gland are bound and transported by serum proteins. Thyroxine-binding globulin, TBG, 75%. Thyroxine-binding prealbumin, TBPA. Albumin. The free, or unbound, hormone levels are the levels which are maintained constant by feedback and regulate thyroid function. Total measured serum T4 includes bound and unbound variations in thyroxine-binding proteins. Causes of increased TBG levels. Pregnancy, estrogens, cirrhosis, hepatitis, porphyrias. Causes of decreased TBG levels. Protein malnutrition, nephrotic syndrome, hepatic failure, androgenic steroids, high-dose glucocorticoids. Free T4, FT4, usually constant in the above conditions. Thyroid hormone action in the tissues. T4 deodonated in periphery to T3. This is 80% of T3 produced. Other metabolite of T4 is reverse T3, RT3, which is metabolically inactive. T3 enters cells and binds to group of nuclear receptors, then affects wide range of cellular metabolic functions. Thyroid hormone required for normal cell metabolism. Feedback regulation of thyroid hormone levels. Normal regulation requires intact hypothalamic pituitary system. Hypothalamus secretes thyrotropin-releasing hormone, TRH. TRH then stimulates synthesis and release of thyrotropin, thyroid-stimulating hormone or TSH, by the anterior pituitary. TSH then stimulates the thyroid gland to uptake iodine, synthesize and release T4 and T3. T4 and T3 levels feedback to both hypothalamus and pituitary affecting TRH and TSH release. Thyroid function tests. Radioimmunoassay for T4, T4IA, is most useful single test of thyroid function. Normal levels 4 to 12 micrograms, DL. Free thyroid hormone difficult to measure directly, so indirect tests developed. T3 resin uptake, TERU, measures amount of radioactive T3 unbound when added to patient's serum. Reflects hash of sites available for binding T4 and T3. Is indirect measure of level of circulating T4. Normal is 25 to 35%. Other thyroid function tests. Free T4 index, FT4I. Correlates with level of free T4. Is the product of T4IA and TERU. T3 radioimmunoassay, less useful. Normal 75 to 195 nanograms, DL. Serum TSH. Normal is 0.3 to 5.0 mq/ml. TRH stimulation test measures TSH response to TRH4 injection. Normal is increase in TSH to 30 mq/ml. Clinical interpretation of thyroid function tests. DERU. Low in hypothyroidism and high TBG states. High in hypothyroidism and low TBG states. T4 and the TERU go in same direction with thyroid disease and in opposite directions with TBG level abnormalities. TSH. Elevated in primary hypothyroidism. If patient hypothyroid and TSH is low, then lesion is in hypothalamic pituitary axis, and TRH stimulation test should be done. Directional changes in thyroid function tests. Clinical state. Total T4. DERU. FT4I. Free T4. TSH. Euthyroid. N. Hyper. Thyroid. Hypothyroid. High TBG. N. Low TBG. N. Non-thyroid. Illness. N equals normal. Medications which may cause euthyroid hyperthyroxanemia. Oral contraceptives. Narcotics, methadone, heroin, pufenazine, clofibrate, 5-fluorouracil, heparin, amiodarone, iodine contrast agents. Disorders of thyroid hormone excess. Thyrotoxicosis is the term for all disorders with increased levels of circulating thyroid hormones. Hyperthyroidism refers to disorders in which the thyroid gland secretes too much hormone. Radioactive iodine uptake test, RAUI, distinguishes hyperthyroidism from other forms of thyrotoxicosis. The radioactive iodine uptake test, RAIU, quantitates the fraction of a dose of radioiodine I-123 taken up by the thyroid gland within 24 hours. Normal is 5 to 30%. Elevated when thyroid gland is overstimulated. Decreased when thyroid gland is suppressed, as by ectopic production of T4 or T3. Is decreased falsely by recent iodine load, as from contrast computed tomography scan. Thyroid scans. Graves' disease. Toxic multinodular goiter with hot nodule. Causes of thyrotoxicosis with elevated RAUI. Graves' disease. Pituitary tumor secreting excess TSH. Pituitary insensitivity to feedback. Hydatidform mole. Choriocarcinoma. Testis embryonal carcinoma. Toxic multinodular goiter. Toxic uninodular goiter, causes of thyrotoxicosis with decreased RAUI. Acute autoimmune thyroiditis may later lead to hypothyroidism. Infectious thyroiditis. Postpartum thyroiditis. Factitious, taking excess thyroid hormone. Metastatic thyroid cancer. Struma ovarii, dermoid tumors or teratomas of the ovary. Medications which can induce hyperthyroidism. Iodine. Amiodarone. Lithium. Also rarely due to ground beef contaminated with bovine thyroid glands. Features of Graves' disease, toxic diffuse goiter. Most common cause of hyperthyroidism, 70 to 85% of all cases. Caused by thyroid-stimulating immunoglobulins. Mainly in young adults ages 20 to 50. 5 times more frequent in women. Half of cases have infiltrative ophthalmopathy with exophthalmos, not seen with other causes of hyperthyroidism. 5% of pretibial myxedema, 51-year-old male who presented with urinary retention and proved to have Graves' disease, Pretibial myxedema and square toes in the same patient on the prior slide. Ophthalmopathy associated with Graves' disease. Asymmetric ophthalmopathy with lag ophthalmos and Graves' disease. Features of toxic multinodular goiter. Second most common cause of hyperthyroidism. Most cases in women in 5th to 7th decades often have long-standing goiter. Symptoms usually develop slowly. Symptoms suggestive of thyrotoxicosis. Nervousness, restlessness, shortened attention span, emotional lability, difficulty sleeping. Increased appetite. Weight loss. Heat intolerance, perhaps low fever. Diaphoresis. Weakness. Menstrual irregularities. Signs suggestive of thyrotoxicosis. Sinus tachycardia, PVCs, PACs, atrial fibrillation. Tremor, hyperreflexia, muscle wasting. Warm, erythematous, moist skin. Alopecia, nail friability and separation from bed. Hyperventilation. Eyelid retraction, lid lag, persistent stare. Hyperactive bowel sounds. With Graves, may have exophthalmos, tender enlarged thyroid, and pretibial myxedema. Patient with thyrotoxicosis from Graves' disease. Onycholysis, irregular separation of nail plate from nail bed near distal end, in the same patient on the prior slide. Possible complications of thyrotoxicosis at presentation. High output congestive heart failure. Dehydration. Electrolyte imbalance, from diarrhea. Corneal lesions from exophthalmos. Worsening of pre-existent angina. Syndrome of apathetic or non-activated thyrotoxicosis. Represents potentially dangerous degree of hyperthyroidism masked by other pre-existent chronic conditions or illnesses. High mortality if not recognized and patient has surgery or another new illness. Most cases in elderly or patients with compromised communication ability. Clinical features of apathetic thyrotoxicosis. May present with any of these seemingly isolated symptoms. Congestive heart failure. Atrial fibrillation. Recent weight loss greater than 20 kilograms. Somnolence, apathy. Irritability and uncooperative behavior. If not recognized and treated, patients may slip into coma and die. Thyroid storm, a true medical emergency. Exact pathogenesis not understood. No clear-cut clinical feature separation from thyrotoxicosis. Represents diffuse life-threatening decompensated dysfunction of the body's metabolism. Cases now very rare and sporadic. Thyroid storm definitions. Exaggerated or florid state of thyrotoxicosis. Life-threatening, sudden onset of thyroid hyperactivity. May represent end stage of a continuum. Thyroid hyperactivity to thyrotoxicosis to thyrotoxic crisis to thyroid storm. Probably reflects the addition of adrenergic hyperactivity, induced by a non-specific stress, into the setting of untreated or undertreated hyperthyroidism. Thyroid storm background etiology. Most cases secondary to Graves' disease. Some due to toxic multinodular goiter. Rare causes. Acute thyroiditis. Factitious. Malignancies, most do not efficiently produce thyroid hormones. Very rare in children. Thyroid storm prognosis. Old references quote almost 100% mortality untreated, and 20% treated, but these reports were before use of beta blockers. Current mortality should be less than 5%, although not well studied or reported due to rarity of cases. Clinical presentation. Thyroid storm. Clinical presentation. Two most important defining features. High fever, usually over 40 degrees Celsius. significantly abnormal mental status, agitation, confusion, psychosis, coma. May also exhibit marked tachycardia, vomiting, diarrhea, jaundice, in 20%. Associated signs of Graves' disease. Precipitating factors. Thyroid storm. Precipitating factors. Infection, especially pneumonia. Cerebrovascular accident. Acute coronary syndrome, congestive heart failure. Pulmonary embolus. Diabetic ketoacidosis. Parturition, toxemia. Major trauma. Surgery. Iodine 131 Rx or iodine contrast agents. Rapid withdrawal of antithyroid medications, differential diagnosis. Thyroid storm. Differential diagnosis. Environmental heat stroke. Cocaine, amphetamine, or phencyclidine toxicity. Neuroleptic malignant syndrome. Meningitis or encephalitis. Intracranial hemorrhage. Malignant hypothermia. Falciparum cerebral malaria. Progression of neurologic findings in thyroid storm. Emotional lability. Restlessness. Hyperkinesis. Confusion. Psychosis. Lethargy. Somnolence. Obtundation. Coma. Cardiovascular findings in thyroid storm. Marked tachycardia. Sinus tach or atrial fibrillation. Increased myocardial irritability. PVCs, PACs, first-degree avenue block. Wide pulse pressure. Apical systolic murmur. Loud S1 and S2 valve sounds. Some have high output CHF. Case reports of unusual presentations of thyroid storm. Coma without prominent cardiovascular findings. Status epilepticus. Non-embolic cerebral infarction. Abdominal pain and fever. Acute renal failure, rhabdomyolysis. Usual indicated initial lab studies for thyroid storm. Glucose, stat finger stick because of altered mental status. Pulse oximetry, +/ABG. CBC, electrolytes, BUN, creatinine. T-phoria, Deru, TSH, +/Turia. Urinalysis. Liver function tests. Serum cortisol. Thyroid storm usual lab results. Lab studies do not distinguish thyrotoxicosis from thyroid storm. Usually T4 and T3 are elevated, but may only be elevated T3. Usually plasma cortisol is low for degree of stress present. Hyperglycemia common, thyroid storm emergent Rx. High flow O2. Rapid cooling if markedly hypothermic. Ice packs, cooling blanket, mist, fans, nasogastric tube lavage, acetaminophen, salicylates contraindicated because cause peripheral deiodination to T3. 4 fluid bolus if dehydrated. May need inotropes instead if in CHF. Propranolol 1 mg doses or labetalol 10 to 20 mg doses 4 and repeat doses as needed. Thyroid storm further Rx. 4-diltiazem +/digoxin for rate control for atrial fib. 4 diuretics if in CHF. 4 hydrocortisone, or equivalent 100 mg. Propylthiouracil, PTU, 601 2200 mg per or by OM. Sodium iodide 1 gram for 1 hour after the PTU. Find and treat the precipitating cause. Additional optional meds. Thyroid storm. Additional optional meds. Lithium carbonate 600 mg per. Follow-on dose 300 mg per TID. Colstipol, resin which binds T4 in the gut, 10 grams per. Follow-on dose 10 grams per TID. Consider sedatives such as benzodiazepines, but beta blockers are the mainstay of therapy. Actions of antithyroid meds for thyroid storm RX. PTU inhibits hormone synthesis by the thyroid gland and also inhibits T4 to T3 conversion peripherally. This is why it is preferred over methimazole, which just acts at the thyroid. Iodine inhibits secretion of T4 and T3 from the thyroid. It must be given after synthesis block from PTU, or else it may provide more substrate for gland hormone synthesis. Lithium can be used in patients allergic to iodine but can cause relapse when stopped. Follow-on doses of meds for thyroid storm. PTU 100 to 300 mg potid. Monitor for later agranulocytosis or liver dysfunction. Or methimazole 20 mg potid. Sodium iodide 500 mg for Q12 hours. Or SSKI 5 to 20 GTTS potid. 50 to 100 mg hydrocortisone for daily till stable, then wane as appropriate. Propranolol or labetalol or metoprolol, same daily doses as for hypertension. Additional RX for thyroid storm not responding to initial RX. Plasma exchange or plasmapheresis. Peritoneal dialysis or charcoal hemoperfusion. Emergency surgery for partial or total thyroidectomy. Myxedema coma, the other thyroid emergency. Represents end stage of improperly treated, neglected, or undiagnosed primary hypothyroidism. Occurs in 0.1% or less of cases of hypothyroidism. Very rare under age 50. 50% of cases become evident after hospital admission. Mortality is 100% untreated, 50% even if treated. Most cases present in winter, cold exposure. General causes of thyroid failure. Diseases of the thyroid, primary hypothyroidism, 95%. Pituitary, secondary hypothyroidism, 4%. Hypothalamus, tertiary hypothyroidism, less than 1%. Can be associated with the multiple endocrine failure syndromes. Etiologies of primary hypothyroidism. Autoimmune, most common. Some have lymphocytic infiltration variant. Post-surgical thyroidectomy. External radiation. Iodine 131 RX for hyperthyroidism. Severe prolonged iodine deficiency. Antithyroid meds, such as lithium. Inherited enzymatic defects. True idiopathic. Symptoms of hypothyroidism. Cold intolerance. Dyspnea. Anorexia. Constipation. Menorrhagia or amenorrhea. Arthralgias, myalgias. Fatigue. Depression. Irritability. Decreased attention and memory. Paresthesias, signs related to hypothyroidism. Dry, yellow, carotenemic skin. Weight gain, 41% of cases. Thinning, coarse hair. Myxedema signs, mucopolysaccharide deposition in tissues. Puffy eyelids. Hoarse voice. Dependent edema. Carpal tunnel syndrome. Anemia. Signs of advanced hypothyroidism. 60-year-old male who presented with fatigue and alopecia. His FTI was 0.2 and his TSH was greater than 75. Same patient on prior slide after 6 months treatment with T4. Hypothyroidism and myxedema coma, cardiac signs. Hypotension. Bradycardia. Pericardial effusion. Low voltage EKG. Prolonged QT interval. Inverted, flattened T waves, EKG of 52-year-old female presenting with fatigue and weight gain. Her T4 was 2.7 and her TSH was 40. EKG of same patient on prior slide after treatment with T4. Precipitants of myxedema coma. Cold exposure. Infection. Pneumonia. Urinary tract infection. trauma, CNS depressants, narcotics, barbiturates, tranquilizers, general anesthetics, cerebrovascular accident, congestive heart failure, myxedema coma. Typical presentation. Usual symptoms and signs of hypothyroidism, plus hypothermia, 80% of cases. If temp is normal, consider infection present. Hypotension, bradycardia. Hypoventilation, respiratory failure. Ileus. Depressed mental status, coma. Patient with myxedema coma. Contributing factors to coma in myxedema coma. Hypothyroidism itself. Hypercapnia. Hypoxia. Hypothermia. Hypotension. Hypoglycemia. Hyponatremia. Drug, sedative, side effect. +/sepsis. Lab studies to order for suspected myxedema coma. Stat glucose, because of altered mental status. Pulse oximetry, ABG usually indicated. CBC, lights, bun, crete, calcium. T4I, deru, TSH. Serum cortisol. Liver function tests. Relevant drug, alcohol levels. Emergency treatment of myxedema coma. O2 +/intubation, ventilation if RISP. Failure. Rapid blood glucose check +/4D50 +/naloxone. Hydrocortisone 100 to 250 mg for cautious slow rewarming, warm O2, scalp, groin, and axilla warm packs, +/ung lavage. Thyroxine, T4 500 micrograms for, then 50 micrograms for Q day. Add 25 micrograms T3 PO or by on Q 12 hours, if T4 to T3 peripheral conversion possibly impaired. Careful for fluid rehydration, watch for CHF. Other aspects of treatment for myxedema coma. Search for and treat precipitating cause. Use lower doses of most other meds. Drug metabolism is impaired and decreased until T4 physiology is restored. Follow TSH levels. Should decrease in 24 hours and normalize by day 7 of Rx. Mechanical symptoms associated with goiter. Frequent. Dyspnea, dysphagia. Fullness, choking or pressure sensation in neck. Less common. Acute respiratory failure. Superior vena cava syndrome. Esophageal varices. Uncommon but reported. New onset asthma, phrenic nerve paralysis, Horner's syndrome, thorax, neck abscess, sleep apnea. "70-year-old male with a substernal goiter causing tracheal compression. Surgical excision of a goiter. Causes of airway distress due to thyroid disease. Preoperative. Direct tracheal deviation and compression. Intrathyroid bleeding causing tracheal compression. Tracheal invasion by anaplastic cancer. Bleeding into trachea. RISP. Failure from pulmonary metastases of thyroid cancer. Postoperative. Wound hematoma. Laryngeal edema. Bilateral vocal cord paralysis. Tracheomalacia.